One of the things that's been really interesting in the last few weeks to watch is the incredible diversity with the way that the Affordable Care Act is playing out from one state to the next. So, and it's largely along political lines. So you see blue states that have expanded Medicaid, that have set up their own state exchanges. The experience of the Affordable Care Act in those states is dramatically different from what a consumer in a red state with a governor who didn't expand Medicaid and whose citizens are relying on healthcare.gov to shop for insurance, their experience of the Affordable Care Act is likely to be more negative. And so if you can imagine the political debate over healthcare becoming even more polarized, it seems like the diversity in the way that the act is implemented from one state to the next will speed that along. So Dora, maybe we can begin with you. Are you surprised with what's happened with the exchanges on the federal level? I think, again, people thought there would be some troubles, but perhaps not on this level. What are your observations from the past few weeks?
So certainly, the time I was asked to participate in this forum, I was hoping that there would be much better news by this point, mid-November. But unfortunately, it seems that there's the challenges both on the policy level, but even more so on the political level, remain just as entrenched. And I'm, unfortunately, I think I share a lot of people's perspectives that, that we're unsure if, in fact, the website will be fixed at the end of November. And I think you're hearing a lot of statements that people are saying it will be mostly fixed or nearly fixed. And so I think my concern is certainly not in isolation. I think certainly with the enrollment, you mentioned that we expect to see the enrollment figures any day. Those certainly will be low and disappointing on some level, although at the same time, I do think that experience is no different than what we saw with Medicare Part D sign up, and certainly some of the experience with the Massachusetts exchange. And so that's another reality that we'll learn more about this week, but certainly the enrollment figures will be low. And the third challenge, I could go on with many challenges actually, but the third challenge, of course, in the last couple of weeks have been with some of the 5% of Americans who have their own individual policies have learned that, in fact, even if you like what you have, you won't be able to keep it because some of these policies are being withdrawn or terminated. And so they will have to get new policies through the exchange. And certainly I'm a glass half full type of person, so but we're expecting about half of these individuals will qualify for the subsidies. But for the remaining, it certainly could be challenging for costs. And there's just the general unhappiness with having to lose a product that they would prefer to keep, despite all the problems with those products very generally. So, so that is a bit of a long-winded answer to no, I'm not surprised. A and B certainly share some concerns over the next few weeks. Certainly, or months to come. But I do think that the story in 6 months or a year or 3 years will not be about the website and all the rollout debacle. The real story, again, will be, of course, the millions of Americans who are now uninsured who will have coverage. It will be about the quality of that coverage and the value. Those are the stories that expect to see a year from now by the end of 2014. And so so I do, frankly, quite optimistic that once we get past these hurdles, that we're going to be well on the path to health reform as we all had hoped it would be.
David, the exchanges are occupying most of the news headlines these days, but they are one section of what's a really enormous change for the broader insurance industry. So how do you at Cigna see the changes in the individual market as being sort of crucial to what's happening across the entire insurance sector, or how does the exchanges fit into what your broader strategy is at Cigna?
Sure. We've positioned our company some time ago as a health service company. So around that, we viewed that health insurance, which is the financing of illness, was necessary but no longer just sufficient. So you needed to expand into prevention, wellness, risk reduction, centers of excellence enablement, helping individuals on a very personalized basis. Secondly is working differently with hospitals and physicians to pay based on quality and value, not just based on volume. So to your point, one, in the US today and over the last several years, we've seen more aggressive adoption of employers around broader prevention, wellness, incentive-based programs, on-site care coordination, on-site health advocates, et cetera, all to the positive. And we're seeing improvements in health status, closure of gaps in care, moderation of healthcare trends. Not perfection, but we're seeing that this environment of change is stimulating many people to take action. Two is in the delivery space with physicians, hospitals, to some degree with pharma, but specifically physicians and hospitals, more openness and adoption to partnering and working in a different way. I think the prior panel, I heard a little bit of reference relative to the phraseology of ACOs. In Cigna, we call them collaborative accountable care relationships. And we believe so passionately in those that we set up our first 8 back in 2008, before the law was signed, to pilot some different models. Today, fast forward to 2013, we have 75 up and running in the United States today, exclusively touching over 1 million lives. And we could point to demonstrable improvements in clinical quality, service and satisfaction, and as a result, lowering of costs. So that's another example of movement. And then lastly, in the individual market, in the US, historically, Cigna has not played in the individual market. Bluntly, we viewed it as a pretty inefficient marketplace in terms of the way it moved. Going forward, we see opportunities to, if you will, play or deliver value in the individual market by applying some of those same lessons. Engaging individuals on a very personalized basis through multimodal preference-based ways of communicating, telephony, electronic interaction, gamification, having a different experience when they go into their physician office if they're experiencing the collaborative, and then engaging an individual around maintaining health, lowering health risks, and then of course, dealing with chronic or acute health care in the best way possible. So long-winded way of saying we're in an environment of unprecedented change. Healthcare reform is around expanding access to insurance, but also very importantly, improving health quality and improving affordability. And that's a journey. It's more of a marathon, not a sprint. And we're experiencing right now as a society many of the challenges of trying to sprint in a marathon, right? I'm a runner and a triathlete. You don't sprint in a marathon. You don't sprint in an Ironman triathlon, right? You got to pace yourself. And we need a lot of intellectual honesty, and now's a time for some bipartisan leadership to come back together around this.
We'll see about that. I am optimistic, maybe. But Jean, what have you observed in Massachusetts? The president came here a few weeks ago when the problems with the website were sort of first coming to the surface, really trying to make the case that Massachusetts got off to a bumpy start as well. Massachusetts does have similarities to the federal health reform, but it is very unique. Massachusetts started from a very different place. So how applicable are the lessons from Massachusetts to the rest of the country?
The devil's in the details, but I do think at a high level, Massachusetts' experience is very relevant to the federal reform because it is the model of the federal reform, and the basic architecture is identical, is very similar, if not identical. I do think that I agree with the points made by both Laura and David. That number one, when you think about the exchange, there is a long-term view and a short-term view, and even though we are in the middle of the short term, it is not really too late to think about the long term. And I think the Affordable Care Act has big plans for the exchange, and what that means is it is intended as far more than just a distribution vehicle for subsidies. What it's intended to do is really to aggregate purchasing power and accelerate changes that the market needs to really embrace, and those changes include some of the elements that David mentioned, which is really changing how the market interacts with healthcare and how healthcare is delivered. I think the way the exchange is going to do that is by making the healthcare market look more like a market, and by that I mean specifically a few things that we might just take for granted. One is that there should be adequate price competition, which means that your biggest players should be the most price competitive. It also means that the market should have a baseline level of transparency in price and value. It also means that your consumers should be shopping actively quite often. If you look at the current markets, at least in Massachusetts, none of these things is present right now. For example, you may not know that there are actually a host of fairly small but pretty good quality health plans that are very cheap, but they're struggling to grow because there is no information about them. People don't know about them because people are not actively seeking information about them. So this is what I call a market that is not functional. The exchange is positioned to change that, if not overnight, but certainly taking some steps. And there are lots of reasons. We don't have time to go through a lot of them right now, but there are lots of reasons for me to feel very confident that the exchange is well positioned to tackle this big issue. But I do want to mention that there is a very important gating factor for this to happen, is that the exchange needs to accumulate critical mass, and it needs to do so very quickly. I can speak to the Massachusetts Health Connector experience. We have historically run two parallel programs. One is a subsidized program, which we did have. We have had critical mass, about 200,000 people, and it has been successful. And an unsubsidized program, which is essentially a storefront of the broader market. And in that program, the success, it was a lot more limited because we did not have scale. So the first program, we were able to achieve annual growth in premium over a 7-year time span, which is quite long if you think about it, of less than 1%, less than 1% on an annual basis. And that was achieved through fierce carrier competition facilitated by the exchange. On the unsubsidized side, we have had less than 5% of the market share and with very stagnant growth. I would say that the unsubsidized program has been a very good source for individuals who are seeking coverage that they otherwise have trouble finding. But I wouldn't say that this program has been a meaningful player in terms of promoting competition and innovation. So we have a long way to go with that. So this is very important scale, and I think exchanges across the nation, as you think about the future, they need to have a growth strategy. They need to have a volume strategy. And then to achieve that, a few things are important. Obviously, in the short term, you have to make sure there's a website that actually works. You actually have to have a front end that can take people's calls and making sure they have good experience. But there are some more fundamental things. Price advantage is very important. Now, that's good news because with subsidies, the exchanges do have a price advantage to begin with. So one thing that is good from our perspective is that by way of the ACA, now we're integrating the subsidized side and the unsubsidized side. And so it's one market, one set of rating rules so that a carrier that is well positioned in a subsidized space is also attractively positioned competitively in the unsubsidized space. So it could be better positioned to gain growth in a broader market as well. I think different states should think about this. If you are a larger state, maybe focus on particular segments of the market is sufficient. If you are a smaller state, you may have to think more broadly about other venues of growth. The other thing that I think is important is that it's really important to work with health plans. So health plans, you need some health plans that really see the exchange as a growth opportunity because it actually takes a lot of investment from the health plan to actually work with the exchange. So that's something that we have done a lot of work to achieve in Massachusetts. I mean, it's one of the advantages to have a state-based exchange because you actually have that local environment. So I think those are very important. Just to sum it up, scale is very important. I think we have a lot of opportunities. Price advantage is something that we need to really leverage, and then we need to work with the carriers, and growth is among the highest priorities of the Massachusetts Health Connector going forward.
Thank you. So David, we just heard about the importance of selling plans on the idea that the exchange is a growth opportunity. Do you see the individual market exchanges, whether run by the federal government or the state exchanges, as a growth opportunity, or is it an inevitable death spiral?
So we've been quite consistent since before the law was signed that we saw that the changing U.S. marketplace presented a potential attractive growth opportunity. And so why do I caveat it that way? Because to be attractive as a growth opportunity, you not only need to have the scale and volume, as Jean notes, but it needs to be sustainable. And sustainable means the environment needs to enable enough innovation, iterative innovation. We believe in incentive alignment and transparency, so enough incentive alignment and transparency for an organization who's going to dedicate the investments, for example, that Jean referenced, to be able to continue to innovate, engage individuals on a personalized basis, and drive sustainable value. So said otherwise, if an exchange is simply a purchasing vehicle to push price controls into the delivery system, we don't think that's sustainable, and nobody is pushing for that today. If it's an opportunity to harness innovation and to create a transparent marketplace, that's very attractive.
And
that's
is
very
that what's
attractive.
happening now, or we're not there yet?
We're in the very early innings, and that's where, in my comments earlier, now is the time when some of the initial stumbles transpire that the long haul objectives need to be kept in mind, because embracing transparency, allowing for some individualism, some personalization in those programs is mission critical, because the more transparency, the more personalization people will want. And if you think about your daily lives, you use more personalization today than you did 3 years ago, and you'll exponentially use more 3 years from today in every aspect of your life, from the coffee you drink to the mobile device you use to your lifestyle. And that needs to take place in these programs as well, especially when you consider that somewhere between 70 and 80% of all medical costs tied to a behavioral lifestyle, right? So let's come back to health improvement. 70 to 80% of all healthcare costs correlate to some lifestyle or behavior. And that's the exciting part of this dialogue. We as a society have the ability to move the needle, to improve health, to create more sustainability from an affordability, from a productivity, from a life quality standpoint. So long as the environment enables you to embrace that, we're all in, and we've been engaged pretty aggressively since before the law has been signed, more on a policy basis, not on a partisan basis, to try to make sure those conversations stay alive in the dialogue going forward.
Jean, what was the response from employers in Massachusetts to the exchange? Did you see, how did you see big companies respond, or was it something that happened quite independent of them?
I would say that Massachusetts is in a very fortunate environment. There is a broad coalition of supporters for the reform. This is not just the ACA, but the Massachusetts version of the reform 7 years ago as well. I would say that that support continues to be present. One statistic point that we have mentioned all along very frequently is that after the rollout of the Massachusetts exchange, there was some speculation that there may be scaled back in coverage offered by the reform, by employers, but it turned out it didn't happen. So there's actually an increase in employer-sponsored health insurance in Massachusetts after the reform, even though there is the exchange option that it was made available to individuals who otherwise do not have coverage options. So I would say that the employers continue to support the reform, thinking that having more people insured is ultimately a good thing for everybody. Employers do need to work through specific changes to make sure they're ready to embrace it. This ranges from administrative changes in terms of figuring out who is subject to penalty and when that kicks in, all the way to having a good appreciation of how rates could change over time. I would say that there is a varying degree of confidence or concern, depending on which side you sit at. I would say that empirically to date, the rates in Massachusetts have been stable, and the market is sort of, for the most part, confident.
Do we have questions from the audience? Yes, over here on the right-hand side, there'll be a microphone coming to you. Oops.
Hi, Angela Sherwin with Brown University. My question is for Jean. When you talk about growth and scaling for the exchange, in Massachusetts in particular, the market of uninsured is fairly small now. So that leaves the potential markets for growth in the employer community and partnership opportunities with Medicare and Medicaid. So I'm wondering if you could talk about some specific strategies that Massachusetts is looking at for how to scale and grow.
Well, first of all, Angela, the number of uninsured is small. That's because a lot of the previously uninsured were able to benefit from the Massachusetts reform, so they're actually now covered through the exchange. So we do have sort of a base volume to begin with. So that is actually very important. It gives us the baseline platform to grow on top. But I think the bigger question is what is that new wave of population that could potentially come in? So there are a few things. One is that the ACA introduces expanded access to subsidies, which could bring new population into the health connector. This includes people who were previously crowded out of Commonwealth care, for people who are familiar with our program. Because one of the changes was if you are eligible to date, if you're eligible for employer-sponsored insurance, whether it's affordable or not, you're not eligible for government subsidies, so that really led to people falling through the cracks. But under the ACA, that is changed. If you do not have affordable insurance, you can access subsidies through the exchange period. So that's a new sort of population. Subsidies going from 300% to 400% of FPL in terms of eligibility, that's an expansion. There are also people like low-income students that previously, again, were blocked from government subsidy. Now they're able to come in. So we believe there are meaningful opportunities for additional growth for the Massachusetts Connector. But more broadly speaking, we think that we have the responsibility to serve people who are not necessarily seeking financial subsidy, but they just want a better experience, an easier, more consumer-driven experience to purchase health insurance. That could include more individuals and small business as well. And then there are 700,000 small business employees and family members in this market, so it's a pretty sizable chunk.
Other questions? Yes, up here in the corner. If you keep your hand raised, the person with the microphone will be able to find you. Thanks.
Hi, Steve Wunker with New Markets Advisors. David, I was intrigued by your comment that the exchanges might offer some more visibility into personalization, consumer engagement, some of the more innovative things that Cigna is doing. But I wonder how that happens beyond your parallel branding and consumer marketing. Does anything happen via the exchange itself that could communicate that?
So to the core of your question, does the exchange itself, from our point of view, does the exchange itself, I'll call it, solve the transparency or personalization issue or opportunity? I would submit no. Does it enable a different environment? Absolutely yes, and let me give you an example. About 8 years ago or so, we purchased a small startup technology company with the notion that what we'll call today exchanges were going to be a part of the future. And it allowed individuals to configure their own benefits from a small series of choices that were based upon their lifestyle and their preferences. And we ran a series of pilots around the country relative to it. And what we learned from that through behavioral economics was as follows. Individuals in general configured a benefit that was somewhat leaner or slightly cheaper, if you measure it that way, than what was going to be given to them for starters. 2, individuals understood those benefits exponentially greater than the alternative of what was given to them. 3, individuals were much more satisfied with the end result of what they purchased. So that was the front end piece. Go to the middle end now when it was operationalized. Individuals became much more active consumers, more retail-oriented consumers. Higher adoption of web-based transparency tools. Higher integration in chronic care programs in terms of medication compliance when they were working with their physicians in terms of understanding that. So I use that as an anecdote to come back that we see the exchanges, broadly speaking, a retail, transparent marketplace that embraces choice and personalization is extremely powerful. Extremely powerful of tapping into an individual's need for personalization and taking some personal accountability aided by, very importantly, aided by a more comprehensive cover that provides peace of mind. Last piece I'll attach into it, my comment from before. Our initial approach is only in 5 states because we historically did not play in the individual market, so we're very focused. In those 5 states for 2014, our go-to-market preferred network is off of our collaborative accountable care relationships because we believe that taking that retail experience I just referenced and the pay-for-value relationship that, again, aligns incentives, has more transparency with the physicians and hospitals is quite powerful. So within that, we have optimism, and we see that the exchange or retail marketplace, as Massachusetts demonstrates, is another vehicle to shed a big floodlight and keep that floodlight on the retail environment.
To follow up on that question, can you achieve the type of personalization that you just described within the federal regulations that are in place, the requirements around essential health benefits, et cetera, or no?
Yeah, so my answer is time will tell. And what I mean by that is today we believe so, generally speaking, optimistic. Each state, as I think people know, have the ability to modify essential benefits. We're a big believer that the base benefit structure should allow for choice to be built up upon it. And we think there's a caution to make sure that the base benefit structure doesn't become so built up upon that there's very little choice for modularity up above that. But let me be clear. We believe passionately that any base offering needs to have comprehensive prevention, comprehensive wellness, adequate network choice, individual responsibility and physician responsibility, catastrophic cover wrapped around that. And in fact, our go-to-market offering to employers typically has 100% cover to prevention, wellness, et cetera, because we don't want any financial disincentive. So my answer is time will tell because we're in the early generation. The states we're operating in today, there's reasonable flexibility. The question is, what does this look like in 2016, 17, 18? Because as Gene referenced, we're, 7, 8 years into it in Massachusetts, and it's still evolving. The key is to enable more choice as we go forward, not to constrict choice as we go forward from our point of view.
Yep. Further questions from the audience? Yes, this lady right here.
Thank you. I'm Barb Spurrier from Mayo Clinic. Thanks for the comments. I'm interested to know, David, a bit about, as we're thinking about truly trying to build a healthcare system that works, beyond the exchanges, what's going on in terms of the sharing across payers? You know, when you mention all of the pilots and prototypes and things that you're conducting in Cigna, how are we trying to raise the bar so we're sharing learning across the payer community?
Yeah, you know, I would submit, look, I've been at Cigna for 22 years and in the space for 25 years. I would submit from my reflection, the industry hasn't necessarily done the best job sharing, collaborating, and driving, I'll call it institutional innovation. I see more of that transpiring right now, and the place where I see more energy around that is what I'll call in the pay-for-value space. So with you tied to Mayo, more dialogue in terms of how do we work with CMS, with Medicare, as an example, and the overall industry to smartly evolve to a pay-for-value system so that those, whether you're dealing with a facility-based delivery system, hospital or outpatient, multi-practitioner, specialty, or primary care, those who are providing the highest quality care as based on evidence-based care protocols get rewarded more and get supported more aggressively. That's the area where I see the most commonality of energy between the administration, between leaders on both sides of the aisle, and within our industry. That notion, which to my mind is a noble path to reward the part of the delivery system that is delivering the most value, that's the area where I see the most collaboration. Secondarily, some bodies will work around transparency. So there's been some industry funding to not-for-profits, university not-for-profits or otherwise, to do data aggregation. So you have a trusted third party, dare I say that in the environment of the NSA issues that we all read in the headlines, but a trusted third party that has the transparency data that is able to, again, bring that to market for the social betterment. But it would be in payment reform where I see the most collaboration right now.
Other questions? Yes, this table just left of center.
Hi, this is Bill Lucia with HMS Holdings. I was just wondering how with the Medicaid and the subsidies being income means-based, how do you manage for an individual or a family that is moving from a Medicaid option, and you know it's the American dream to earn more, so moves up to a subsidy, but has an entire different choice of plans and networks? How do you manage that? And what disruption does that cause as people move in and out of those different income barriers?
The important question of churn is the term in the industry.
So
Jean?
I can take a stab at that. It's not easy, but it's something that is done before. So if you look at our experience in Massachusetts, that is exactly what we have been trying to do, hopefully somewhat successfully, which is managing a churn in a way that is not sort of overly disruptive to members, do not cause disruption. So one of the things that Massachusetts has done, if you look at sort of the subtle difference between the ACA and the Massachusetts experience, is that when we implemented the reform 7 years ago, we made a decision to really leverage the Medicaid infrastructure That means it's the same eligibility determination system. That means it's actually the same set of health plans that were initially included in this program, that the newly expanded subsidized program. So that members, as they go in and out, some of them could be basically facilitated in terms of the transition without even members' over-involvement. And that is, to some extent, the dream, if you will, because this kind of churn does happen quite often. I would say that over time, members do have sort of the chance to learn a little bit about what's going on, so they know that as sometimes things change, there are a set of procedures that will follow. They get a notice, they get a call from us. We do call them a lot, and then they will sort of receive different types of options. I think that this is something that different states, and us included, will continue to have to work on pretty closely. One of the things that we have, again, in Massachusetts decided to do, which is a little bit different from several other states, is that we developed a new system, the IT system and surrounded ancillary sort of functionalities, really around this no wrong door concept, so that people can come in, they will be navigated to different places, but at the same time, if their situations change, there will be coordinated transition efforts. So it's not easy, but it's doable.
And I would point out that the ACA did have a specific provision to address that point, providing states with the option to establishing a basic health plan targeting those individuals with incomes around 200% of the federal poverty level. The guidance has not been forthcoming just yet. It's unfortunately on the back burner, but I do expect that we're going to continue to see efforts to capture that very unique population and address their concerns.
Right.
One last question from the audience. Yes, all the way in the back.
Vasilios, it's Miklis from Sectoral Asset Management. My own view of the ACA and the exchanges is that it's a good step, a good first step in the right direction. However, one item it fails to address, at least yet, is the issue of price transparency with regards to what hospitals pay to insurance companies, or rather the charges that hospitals charge to insurance companies. Going forward, will there be an attempt to tackle this problem under the ACA?
David, that might be a question for you.
Sure. So I think several comments were made today relative to the importance we'll talk about around transparency or pay for value. The ACA, I would say, understands that and indirectly address that. That dialogue is taking place in Washington as we speak today. I mentioned CMS, Medicare. Medicare pays, a little bit of data a couple years ago, well over $1 billion every day of medical claims. So the big opportunity here is to harness the purchasing power of Medicare to move from a pay for volume to a pay for value, which requires more transparency to be lifted. And that's an area where there's an opportunity for collaboration. I don't think we should look at just the law or a single law to be able to drive that. There's opportunity for market forces to drive it. The collaborative accountable care relationships drive toward that today. There's innovative leaders in the hospital and physician delivery space that are driving toward that today. There's numerous technology startups that exist today that provide price and quality transparency for what's available in the marketplace. And I think what you'll see is over the next couple of years, through both legislative move, regulatory prompting, and market forces, you should see more and more transparency going forward, where employers are pulling for it, individuals are pulling for it from a demand standpoint, and regulators and legislators are beginning to push on that in the marketplace. We believe that that is a critical enabler to value creation going forward, a critical enabler to value creation going forward. But my caution here is I wouldn't look to just the law or the ACA to solve it all. The law needs to put a spotlight on where we need to innovate, whether it's through regulatory forces, capital market forces, base innovation, or some prompting of the law. This is where you have a combination of all of the above. The area I encourage you to look is watch the movement of Medicare over the near term, and some bills have already been floated relative to moving Medicare to a pay-for-value infrastructure over the course of the next handful of years.
Yeah, I think this question of transparency is going to continue to be a hot topic going forward. I've always thought about shopping for health care being equivalent to buying a house without seeing it and then signing your mortgage contract written in Aramaic. So something kind of like that. Hopefully we'll improve on that in the near future.